Much of what we call aging is nothing more than an accumulation of a lifetime of physical inactivity.
The capillary to fiber ratio increases.
Exercise training may actually improve the nutrition of cartilaginous tissue inside the joint.
If physical activity was inherently enjoyable, our problem would be to get people to do less. But in fact, what we have to deal with is getting people to do more.
Push, 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 push. Okay, excellent. Come on back, come on back.
With the increase in the load from the 1 kilopound to the 1.5 kilopound.
How do we motivate physicians to get them to view exercise as a legitimate form of medical therapy?
We're going to be taking the speed and the grade up a little bit.
It can be something as simple as, well, Mrs. Jones, how are you getting your physical activity these days? The modern hypothesis that exercise or physical activity reduces the risk of certain cardiovascular diseases was probably first formulated back in the mid-1950s by Dr. Jeremy Morris in London. Some of his initial research involved looking at cardiovascular disease or coronary heart disease rates in bus drivers and bus conductors who work on the red double-decker buses that run up and down London streets. He found much lower death rates in the conductors than in the drivers, and he attributed this to the conductors' physical activity on the job that they got by climbing up the stairs in the bus to collect the fare from the people on the top deck. Dr. Ralph Paffenbarger has followed a large group of Harvard alumni for more than 20 years. He first surveyed this group of men in the early 1960s, surveyed them again in 1977, and has followed them for mortality at this point through 1985. So when he looked at the men who were sedentary in the early 60s, some of them stayed sedentary on up through the 1977 assessment. Those men have the highest death rate. Some of those men who were sedentary in the early 60s, however, converted their lifestyle and became more physically active. Their death rate is as much as 40% lower than the sedentary men who stayed sedentary. In fact, changing activity, becoming physically active, seems to be one of the most important health actions that this group of men could take. It's essentially established, or as close to proof as we ever get in science and medicine, that sedentary living habits increase the risk of developing certain cardiovascular diseases.
Everybody ready? Let's go!
Walking is something we were designed to do. It's something that we do naturally, and it's something that we simply have cut back on artificially.
Walking is probably one of the single best exercises for total fitness. People enjoy it, and we have very few injuries. So for long-term maintenance and safety of programs, walking is probably one of the best exercises.
We performed a study in which we took 100 sedentary women who were aged between 20 and 40 years. We randomized them into 4 groups. The one group remained sedentary for the 6-month study period and served as a control group. The other 3 groups walked 3 miles on 3 to 5 days each week, but at different speeds. What we found is that when it came to fitness, the faster the women walked, the greater was the improvement in fitness. However, from a health standpoint, health benefits were not related to the intensity of exercise or the speed of walking. The major message from this study is that when it comes to health-related benefits, people can go out and participate in moderate intensity exercise and derive major health-related benefits. You don't have to go out and run marathons in order to improve your health.
One of the things that happens with age is that all of your functioning, your psychological, cognitive, physiological functioning tends to slow down.
We lose about 6.5 pounds per decade of lean body mass as we grow older.
Push, 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 push. Okay, come on back, very good. Push, 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 push. Come on back all the way.
Reduced muscle mass also decreases basal metabolic rate, so that older people require fewer calories. Unfortunately, most older people don't reduce their caloric intake to match their caloric needs. The other thing that happens is they increase their percent body fat. Aerobic capacity declines. There's an increase in blood pressure. There's an increased risk for developing diabetes, decreased insulin sensitivity. There's increased risk for developing osteoporosis. Cholesterol levels go up with advancing age. And finally, older people tend to be more dehydrated and tend not to be able to regulate their internal temperature as well. And all of those things are quite correctable by exercise.
With the increase in the load from the 1 kilopound to the 1.5 kilopound that we're planning for tomorrow, right? That will get your heart rates closer to target.
There's tremendous potential for the elderly to become more active, that by being more active, they're far less prone to injury, they're less apt to fall, they're less apt to trip themselves up, and if they don't do that, they're not going to break the hip. If they don't break the hip, they're not going to end up in the nursing home. If they don't end up in the nursing home with a broken hip, they're not going to die before they have to.
We expect that as we grow older ourselves, that we'll be able to retire and sit down and take it easy. But in fact, quite the opposite is what we recommend.
All the skeptics have been saying for years that you fools who are out there running are wearing out your knees and hips, and you're going to be cripples later in life and going to have all kinds of osteoarthritis. Well, what is the evidence for the relation between physical activity and osteoarthritis?
If you review the major studies that have been performed in this area, there's no evidence whatsoever that regular participation in exercise increases the risk for osteoarthritis. There is, in fact, a number of reasons why we should believe that exercise may reduce a person's risk of developing osteoarthritis.
We've looked at lifetime running miles, the number of years running, the miles run in the past year in relation to risk of developing physician-diagnosed osteoarthritis. We've done this in a population of several thousand men and women, and in fact find no relation between any of those running variables and the risk of developing osteoarthritis. The women who were running were slightly less likely to develop osteoarthritis than those who were sedentary. So I think the evidence that we have at this point suggests that running is not wearing out your joints. And in fact, the animal literature quite clearly shows that exercise improves joint function. You get more synovial fluid, you get a thicker cartilage, you get stronger ligaments. So I don't think we need to be very concerned about the risk of osteoarthritis from an active lifestyle. One doesn't have to be an Olympic level athlete in order to be fit enough to get a lot of health benefit.
The American College of Sports Medicine guidelines have basically been established to help people gain in cardiorespiratory fitness and to be able to gain minimally in their basic levels of strength.
The more recent data is overwhelming on the importance of specificity of exercise. If you train the legs, the arms will deteriorate and not get the fitness benefits. So we must do well-rounded programs to protect the upper body, protect the lower back, as well as to generally maintain muscle mass as we get older.
According to the American College of Sports Medicine, if a person wishes to perform low to moderate intensity exercise, then they do not need exercise testing unless they have symptoms of disease or known cardiopulmonary or metabolic disease. On the other hand, if an individual wishes to participate in higher intensity exercise, then they should undergo exercise testing if they are male and over the age of 40, female and over the age of 50, irrespective of their age, if they have 2 or more major coronary heart disease risk factors or symptoms of disease or known cardiopulmonary or metabolic disease.
We know now, though, that you can gain considerable health-related benefits from more modest levels of exercise that will really not lead to improvements in what we would traditionally call cardiorespiratory fitness. And I think that's very important because I think we're going to get many more people involved in basic low-level fitness activities that can gain the health benefits without necessarily becoming much fitter.
We know that when you exercise, you get very sore. It's called delayed onset muscle soreness. And muscle soreness is caused by microscopic tears in the muscle that ultimately must be repaired. These microtraumas in the muscle cause the muscle cells to swell up and become edematous. It's the swelling that occurs 24 to 48 hours after the exercise that causes soreness. The damage also causes what we call an acute phase response that's elicited by neutrophil generation and invasion of neutrophils in skeletal muscle. And perhaps the process itself is mediated through the production of prostaglandin stimulated by interleukin-1. So the cytokine or interleukin-1 stimulated prostaglandin cascade that ultimately causes muscle protein degradation and repair is only one of many mechanisms by which muscle repairs itself. If you want to try to reduce the soreness, it's our belief that taking an analgesic that would not be a prostaglandin blocker might be the best way to go. Agents that block prostaglandins taken perhaps as an analgesic might in fact delay or blunt this training response.
Physicians and medical personnel often forget what putting someone flat on their back in bed can do to them physiologically.
3 weeks of bed rest is equivalent to 15 years of aging in terms of its effects on aerobic capacity.
When you have someone in bed rest, which most people with chronic diseases are at some point in time for varying length of time, you lose an awful lot of muscle strength and muscle mass.
This time we're going to do straight up. Up.
There are reports of people going to bed with normal glucose tolerance and 3 weeks later being diagnosed as being diabetic simply due to the bed rest.
Up. Are you getting tired?
No, I'm enjoying this. This is the highlight of my day.
And down.
Leg lifts or arm lifts or using a trapeze or arm pulleys while they're laying in bed is much better than just laying there. I think what's important is to get people home, moving, and gradually progressing to optimize their functional capacity. And at some point in time, somebody has to tell them to move.
At age 40, 50, and 60, you might be exercising to prevent the onset of chronic diseases. But at age 80 and 90, one should be exercising to prevent a further loss in strength. There's no reason to believe that older people are going to respond any differently than younger people. So the same kind of frequency, intensity, and duration of exercise that we know stimulates